Perfect. Yes, thank you.
All
Go
right.
ahead.
So I like to call them out of book fractures because they are pretty unusual. Normally, you don't see elbow dislocations in a child as frequently as you would see probably a supracondylar or a lateral condyle fracture. But elbow instability does occur in children and can come in various forms. Now, this is an example of a child who had a posterolateral dislocation of the elbow, and you can see that there is a small bone fragment there. This is another elbow dislocation. Also, this has a small fragment in front of the capitulum. Also, this is another elbow dislocation with a large chunk of bone on the outer aspect. And this is yet another dislocation with some flakes of bone around the elbow. So it's always very interesting because an elbow dislocation in a child will have some bits of bone around the elbow, and each one of this is a different diagnosis. The first X-ray that I showed you had a medial epicondyle avulsion fracture with a dislocation. The second X-ray was a radial neck fracture with an elbow dislocation. The third is a unstable lateral condyle with elbow dislocation. And finally, there is an olecranon fracture with a radial neck with an elbow dislocation. So it's important that we look at the x-rays very carefully to find out where that bone piece is coming from. And more often than not, we will need additional investigations in the form of MRIs to find out more about how to treat these children. So when you have a medial epicondyle fracture, I'm going to go through all of these one by one and just show you what are the current guidelines and how we manage these. So when you reduce the elbow, you must always look at where is that medial epicondyle lying. Very often you will get a good congruous reduction and you will find that the piece is lying away from the medial epicondylar where it should belong. And then you need to make a decision whether you can conserve this, treat it just with a plaster, or it needs to be fixed. More often than not, when it is associated with a dislocation, the elbow is highly unstable, and it is always a good idea, especially in young athletes and high demand elbows, that we treat this surgically and fix that piece back where it belongs to its bed. But we always should use a cancel screw and give good compression so that we get an excellent outcome. K wire is really not an option for these kind of treatment. But here in India, we often see patients coming quite late. Now, this child was treated by a local bone setter, and that piece of bone got trapped inside the elbow joint. And he came to us in a plaster cast, something like this, with a stiff elbow. So he came at 4 weeks with a stiff elbow and an x ray which looked like that. So further investigations did confirm that there was a medial epicondylar piece which was trapped in the ulnotrochlear joint, and there was a lot of callus around the elbow. But that piece of bone definitely needs to be removed and arthrolysis needs to be done, otherwise good function cannot be restored. So this is where we go ahead with the medial approach, dissect the ulnar nerve. If it is swollen or there are ulnar nerve symptoms, we will transpose it anteriorly, but we will bring that fragment from the joint, take it out, put it where it belongs. Sometimes, if it's too comminuted, you just use a suture anchor and tie the common flexor origin back where it belongs, but get rid of what is obstructing the joint. And if there is a decent size piece, then you can put it back again and do an elbow arthrolysis with an anterior capsulotomy, and then start the child on a rehab protocol so that eventually by the end of a year, 2 years, you can see that the child regains decent function. So medial epicondyle avulsion with elbow instability is one of the common fracture dislocations, and it's important to look at where the medial epicondyle lies. There's a substantial variation amongst pediatric orthopedic surgeons while treating the medial epicondyle. The decision to operate should be influenced whether there is an elbow dislocation or there is no dislocation. And these papers, which I have shown you here, highlight that most of the times displaced fractures can heal even without surgery. Open reduction and screw fixation has not shown to improve outcomes, provided there was no dislocation and the displacement was minimal. But what is the indication for surgery? Any displacements about 10 millimeters, incarcerated fragments with elbow dislocation, open fractures, ulnar nerve symptoms, or a high demand elbow in an athlete or a gymnast. It's always a good idea to fix these, and you will have a decently stable elbow with a good outcome. The message is also take an oblique view to know whether the fragment is entrapped, because an AP or a dead lateral may not actually reveal the entrapped fragment, and a CT scan or an MRI should be done. Let's move on to the second elbow dislocation that I showed you. Now this radial neck fracture, you can see along with that there is an elbow dislocation. And when we reduce it post reduction, you can see that the neck and the head of the radius is tilted at 90 degrees to the shaft, and this is not acceptable. So we will need to do something to relocate the radial head where it belongs. Now this can be done percutaneously. You know that Jeffries has described this into two types, the type 1 and type 2, where the radial head gets fractured and head remains out either in during the dislocation or during relocation, depending on where the head is lying, either posterior to the elbow or in front of the radial neck. And the approach to treatment would change depending on what is happening, where is the fragment lying. And you could do a percutaneous leverage technique and get a sort of a reduction and use a K wire to just stabilize that. And you need not have a perfect reduction. You need to just bring the radial neck down to acceptable limits. And acceptable, by acceptable, I mean about 30 degrees of angulation or 30% translation can be accepted. And if, as long as you keep it closed, the chances of avascular necrosis are prevented and are minimized. Sometimes you can do an intrafocal fixation like this, or you could use the Metazoo technique and use an elastic nail to relocate and stabilize the head after your elbow dislocation has been reduced. So this is how it heals with the Metazoo technique. This is the next instability that I can demonstrate. Now, Milch has described the elbow dislocations into two types, the type 1 and the type 2. But here, when you have the fracture line of the lateral condyle going way medial to the medial crista of the trochlea, then it becomes an unstable elbow with an lateral condyle fracture. So as you can see, the type 1 and the type 2, the type 1 is what we see commonly, where the fracture exit is to the lateral side of the trochlear crista. In type 2, the entire piece with the elbow can get dislocated, as I showed you in the earlier X-ray. And this again needs to be fixed accurately with either open or a closed maneuver. But it's important that we do a stabilization with bicortical pins. Sometimes a screw may be used, but an arthrogram will tell you much better about the articular congruity when you do this reduction. The third variant of elbow instability is a Monteggia variant, where you have a radial neck and a very proximal ulnar or an olecranon fracture, as you can see here. And this kind of an injury again can be tricky because it is missed. Again, an open reduction is not mandatory each and every time, and you can definitely do a closed reduction, as you can see here, by longitudinal traction under anesthesia. And then you can put a percutaneous K wire and stabilize the olecranon fragment, and you can do an arthrogram later and confirm stability after putting a little bit of dye and confirm that the elbow is stable, the olecranon is reduced well, and then a plaster for about 3 to 4 weeks. That allows you the advantage of pulling out the pins without a second surgery in your outpatient department. And after the fracture heals nicely, you can pull out the pins. This is after removal, and the child will have a very good function. Sometimes when you have an concomitant radial neck fracture, a percutaneous fixation or an intrafocal fixation of the radial neck can be done simultaneously, and again protect it with a sort of a cast, a soft cast for about 3 weeks to 4 weeks, and that should do the trick. And then you pull out the pins, and once that is healed up, this is the situation. and the fracture has healed nicely, and the child regains his function very well. So it's important that we diagnose them correctly. This is an older child with a olecranon apophyseal avulsion fracture with an elbow instability. Again, the apophyseal avulsion of the olecranon conservative treatment may not be successful, especially in older children with significant chances of redisplacement. Options are open reduction with tension band wiring, but we prefer to use a vicryl suture rather than a stainless steel wire when we do a tension bind to prevent injury. And it's much easier to remove the K wires when there is no stainless steel or an hard wire to remove. The displaced olecranon fractures, again, the biomechanical analysis of fixation methods have shown that the strength of a wire and suture method both can be good at low loads, but at very high loads, the wires, a stainless steel wire scores better than a simple suture around the olecranon tip. But very young children, a bioabsorbable suture can also be used, thus avoiding the need for extensive surgery as well as a second operation to remove that fixation material. This is another subtle fracture dislocation which I want you to understand. This was a national swimmer who used to have the elbow popping out every time they did a backstroke. And what we found on the AP X ray was nothing significant, but on the lateral, there was a small flake of bone behind the capitulum. And advanced imaging showed us that it was a sleeve fracture, a posterior kind of an osteochondral sleeve fracture from the back of the elbow with a capsule attached to it. So this was an osteochondral sleeve from behind the elbow where the capsule was attached and the child had some hyperlaxity syndrome with it. And that allowed the elbow to subluxate in hyperextension. So this piece was dissected out. This was a delayed presentation fixed with a couple of Herbert screws. And that is how the fracture healed over a period of time and went on to satisfactory union. This is another example of a subtle instability, not a frank dislocation. A 9-year-old boy who came to me 4 to 6 weeks after his index injury with a posterolateral elbow instability. On the first view, the x-rays seemed normal, and earlier orthopedic surgeon had actually sent him off saying that there's nothing wrong with you. But when we drew the radiocapitular line, we found that the radial shaft was subluxated posteriorly. And advanced imaging showed that this was an radial head osteochondral fragment where the shaft had subluxated posteriorly and was blocking the extension of the joint. So this was a radial head osteochondral fracture, and we had to fix it using Herbert screws. And again, as you can see here, a delayed presentation, but restored with a small Herbert screw, and then the head rotating nicely. And then the child went on to heal quite nicely, and he had very good function, and he was training to be a boxer, and he went back to his sport and regained his extension as well as good strength. So that is his function later on. And at 5-year follow-up, he's a national boxer today with a good function. And we've removed the screw then. He had some irritation around the radial side, and I took the screw off. This is yet another 12-year-old child with an injury to the elbow. Again, the X-ray was deemed innocuous and was sent off. He was just put in a slab support, a back slab, and he went off. 1 week later, he came with persistent pain and stiffness. And an MRI was done, and the MRI now showed that there was an osteochondral fracture from the inferior part of the capitulum, and the osteochondral piece was actually lying behind the radial head and neck. But this was not seen on X-ray, and then he was lost to follow up. I think this was during the COVID times, and he went off and came back 4 months later with a very stiff elbow. And this is how he came with a flexion deformity of about 50 degrees with further flexion to about 90. And at surgery, when we opened him, we found that the radial head had got significant cartilage damage, and we had to excise the radial head, as well as there was a chondral ulcer on the capitulum. Both were degenerated, and there was arthrosis with stiffness and pain. So we removed the radial head and the fragment, and ultimately had to do a radial head excision. He regained his elbow function, but there is residual valgus instability, and all this could have been avoided provided we had picked up the injury primarily and then treated it appropriately. But the eyes don't see what the mind doesn't know. So it's important to understand that osteochondral fractures can be there around a swollen elbow in a child with subtle instability, and it's important to look for them and fix them. So that is, on revisiting the CT scan, you can see that osteochondral fragment lying behind the radial neck, and we should have picked it up and fixed it. So if you look at literature, capitular fracture, the osteochondral fragments, two types have been described, the Hans-Steenthal and the Cocker-Lawrence types. And it's extremely rare in children, with very few case reports in literature for these chondral or osteochondral fractures of the capitulum. Uh, Again, this 12-year-old child who had a fall from stairs, the X-ray looked innocuous, but there was subtle shadow in front of the elbow. And again, it's important to know that coronoid fractures also can happen in children, and an advanced imaging in the form of a CT scan or an MRI scan will confirm diagnosis for you, and you need to appropriately treat them with pull-out sutures. Uh, like an adult, the elbow will become unstable if you don't do that. And this is an example where an open reduction with a pull-through stitch over an endo button was done. And that is how it healed nicely at 6 months with a decent function. And this case report has been published in JOCR. Isolated avulsion fracture of the coronoid requiring open reduction. Again, another case report with the Journal of Medicine. And finally, this is a 5-year-old boy who had a fall from a bicycle with an elbow which was dislocated. And when you took a plain X-ray, you saw multiple small bone flakes around the elbow. There were at least 3 flakes that could be seen. One was here, the second one was there, and the third one was here. So what are all these fragments? So additional imaging, as I said, most of the elbow in a very young child is cartilaginous, and osteochondral fragments need to be investigated. So this was a terrible triad of a pediatric elbow where there was an elbow dislocation with a coronoid fracture and a radial head fracture and an olecranon osteochondral fracture. So this is what was the situation on opening. And you see that the osteochondral sleeve fractures, and each of these, the olecranon, the radial neck, and the coronoid, all three had to be identified and then fixed up with a suture, pull-out suture for the coronoid. And then we had to put a K-wire, couple of K-wires and a suture for the olecranon. And the radial neck was stable, so nothing needed to be done for that, and was put in a plaster. And then that healed nicely, and this was a 2-year follow-up for the same child. So terrible triad injuries do happen even in young children. You need to recognize all components, and most of these will need surgical intervention, but always keep a long follow-up for growth disturbances. Uh, this is another child with elbow instability. As you can see here, his elbow was unstable. Now, this is the final case that I want to show you. A rare case again. There was stiffness. He did not have full range, and he had instability on valgus stress. And the X-ray was something like this. So again, an extremely unusual, if you see the X-ray very critically, you can see the radial head has actually gone onto the medial side. So this was a translocation. This was a translocation injury where an open reduction was required to put the radial head back on the lateral side, and a simple open reduction and then a plaster, and it healed nicely. So radioulnar transposition is very rare and is usually missed. The etiology is a fall on an outstretched hand in supination. Sometimes you may mistake it as a normal X-ray, but you need to know and look very critically as to whether the capitulum and the radial head and shaft are lining up nicely. So you need extra vigilance. Early detection and prompt intervention can give good outcomes. But these are the various elbow dislocations that happen in a child around the elbow. And it was a pleasure sharing them with you, so that we are all familiar with the different kinds of elbow instabilities in a child. So thank you very much, Sebastian, again. And I'll be happy to answer any questions if there are.
So thank you very much for this great presentation. You have nicely shown the plethora of possible dislocations and different types of dislocations in the joint. I would just like to add, I have also seen a few patients with a dislocation and they actually had a coronoid aplasia. We published the early case of that. Have you seen that as well?
No, no, that's again an interesting thing. If you have a dysplastic coronoid, yes, the elbow would be unstable, but I haven't seen one.
Okay. So we have a question from the audience. A rather long one. When you see a patient with a medial epicondyle fracture in clinic, it's not always clear whether they had a dislocation with spontaneous reduction at the time of injury. How do you decide on treatment? Because instability is difficult to assess clinically due to pain. Is displacement on the CT important or not? Maybe you want to comment on that?
Yes, yes, yes. That's a very good question. The clue to whether it was a spontaneous reduction of a dislocation is from the soft tissue swelling. We have a medial epicondyle injury without dislocation, there will be significantly lesser soft tissue swelling on the medial side, and bruising is definitely much lesser. A elbow which went out, popped out and came back and sat back in will have significant soft tissue swelling and very likely bruising in on your clinical evaluation. Also, even gentle valgus stress will make the child very uncomfortable, whereas a simple epicondyle avulsion without an elbow dislocation, the soft tissues are not as badly damaged. They might have local tenderness, but there will be very little bruising or swelling. Usually I see them at adolescent age group when the children are arm wrestling, and they can have a little avulsion without dislocation or a small fall. So one way is clinical, and second, as you said, is a CT scan, because the displacement on plain X-rays is always underdiagnosed. A CT will always show you the true nature of the displacement of the fragment. And more often than not, more surgeons are moving towards operative management rather than leaving it for conservative treatment, because it usually malunites and may leave behind a small flexion deformity. And the absolute function of a young child as he grows older, if it's unstable, is not very good. So I would definitely do a CT and probably fix even those without a dislocation.
Yeah. So, from the overall cohort, because the literature has almost no information on that, how high, in your opinion, is the rate of residual elbow instability? So from humeral-ulnar dislocation. So on overall, if you mix up all the cases with the medial epicondyle fractures, treated non-operatively, operative, what is the rate of residual instability?
So you're saying after treatment or before treatment?
After treatment, so after treatment, whether it's conservative or
If Yeah.
surgically,
So
you have
as I
you
said,
have an
most of
impression how high the rate is? Because I don't. I
no,
did literature search.
no,
It's
no. What happens with these osteochondral fracture dislocations is usually, if they're not treated well in our country, what happens is they end up painful and stiff. Residual instability, they will not come to you with, they will come to you with an stiff, painful elbow. That is the problem that we see. And they should have been treated and diagnosed on day one rather than having to do an arthrolysis and trying to restore range later
sure.
on.
Mm.
That's because of a lot of bone setters trying to do a lot of uh, conservative treatment and patients not coming on time, really.
Yeah. Yeah, correct, correct. So I would like to send your interest to the chat function. Dr. Kozin has posted an interesting article from Eric Edmonds about how displaced are non-displaced fractures actually. So maybe you all would like to have a look on this paper. Any other questions from the audience?
I would like to know about his experience in radial head, no radial neck, but radial head fractures in children.
Those radial head fractures, again, the subtle subluxations are known to happen on a delayed. It's important that you diagnose them. See, less than 5 years of age, the radial head is not ossified well. So these are all, as they are called, as trash lesions, right? The trash lesions paper was published in JPO. I think Dr. Kozin was one of the co-authors, along with Peter Waters was the primary author. And the paper did speak about being very vigilant about radial head fractures or osteochondral fractures, especially younger than 5 years, because a swollen elbow with nothing seen, you need to be aware that these fractures exist, and we need to definitely get additional imaging done. Plain X-rays are not sufficient to diagnose, and if you have suspicion, if it's a swollen elbow, which is painful in a child and nothing is seen on X-ray, don't trash the X-ray. Get an MRI. You might be surprised to find a cartilaginous injury which needs intervention. And unless we have awareness, we are going to miss many or more of these.
Can I add a
Thank you.
comment? I think that's such a great take-home point, that the swollen elbow, if the X-ray doesn't match the clinical exam, you have to keep looking. And we looked at our intra-articular radial head fractures. Man, if we didn't catch those early in kids, the results are terrible. And so that's something for the trainees on the call to understand, that I don't understand why this is, but an intra-articular radial head fracture in a child is a really bad and unpredictable injury. And that's not the case in an adult, right? An adult, you're like, Mason 2, they don't have a block to motion, give them a sling, they'll be fine. And that's not the case in the children. So that's a really great point, Francisco.
And just to emphasize, you can saw on the X-ray that Sandeep showed, it was subtle.
Recording in progress.
That's a subtle posterior lateral sag. It's not so evident all the time, right? Unless you draw that line. But even some of the ones that we've treated acutely, and have not done well. There's something about that injury that's bad. The Saltires 3 fractures, Ben and I have talked a lot about it. It's just it's such a bad actor. It really is.
Yeah, I think it's like what you were doing, Andy, with the MRIs. Realistically, every child with a injured elbow below the age of full ossification should probably get an MRI. That if cost was no object, right? That's what we would do, right? There would be no question, because in a lot of these kids, they're still unossified. So I totally agree with you. It's a huge problem, huge problem. And even if you recognize it, it's still a really bad actor.